Dr. Sri Ganesh, just a general question, any person starting a fake IOL, again and again they would ask, what is the lowest or the lower limit of anterior chamber depth would you attempt? For let's say a regular ICL or a IPCL, and if it's a toric, what is the lower limit, provided the angles are normal? Angles, every other architecture, yeah.
You have to realize that this is a phakic eye. It is different from cataract surgery, where you remove the lens and you have a much larger space, about 4.5 plus around 3, almost 7 millimeters, whereas here you just have about 3 millimeters. You actually have half the space to manipulate. So when you start off, I think it is better to go by the company recommendation, which is 3.2. Now my lowest, ACD, 3.2.
Above 3 is recommended.
Now I do even 2.6. 2.6 also, you have to be very intelligent in your selection of the lens, because then the error for tolerance is very small. The margin for error is very small. Your tolerance is very less. So ideally 3.2, and then with time, as you're doing more cases, 3 millimeters. 3 millimeters is a kind of cutoff. You become more experienced, you do 1,000, then 2.8. You do 5,000, then I think Shimizu's cutoff is 2.5. Because he has his new nomogram. He has developed certain, he has observed certain things and developed a nomogram where he is able to get almost 82% of his eyes within 100 microns of predicted vault, which is very good.
That's really good, because
2.8 is, if you're a skilled surgeon and you have your nomograms right and your sizing right, then 2.8 is also okay. But you have to realize that 2.8, if you're going on a lower vault, if you have a low vault, the lens is going to grow with time, and then your vault is going to get shallower as the patient becomes older. And then if you have a touch, then again the risk of developing cataract is more.
If there is no astigmatism, is there a refractive power cutoff beyond which you will go for an ICL and below which you will go for a
you can do, see,
cornea?
in all cases of abnormal topography or very thin corneas, I prefer an ICL. I've done an ICL even for like 2.5 diopters. Keratoconus, early keratoconus, stable keratoconus.
No, I'm saying a patient comes to you with say -6, -7, -8, no astigmatism. Which ones would you decide to go in for SMILE or for LASIK, and which ones would you go in for an IPCL or an ICL?
If the topography is perfectly normal.
Everything is normal, everything else is normal.
Everything is normal. Again, it depends. I would prefer to go in for a corneal refractive surgery because it's more on the surface. Once you open the eye, the risks, though they are rare, risk of retinal detachment, risk of endophthalmitis, all that is there. So that's
wherever you can safely do,
you can very safely do a corneal refractive procedure. You do a corneal refractive.
So there was a meta-analysis of a randomized trial where they looked above 6 diopters, where you compared the refractive, laser correction and the lens. They found the lens much safer and more predictable than the laser. That is very surprising. But actually, in terms of predictability of this one is becoming so much more accurate. You don't have to worry. If it is aligned, then you rest assured you have a really good visual acuity.
In fact, countries like Japan, in Japan, hardly anybody does corneal refractive surgery now. It's mainly ICL. ICL has grown in Japan, in Korea, and China. China also, there's a huge increase, and they have crossed over 1 million lenses, and this growth has been there in the past 2 years. So suddenly it has increased.
It is completely,
Because there are a lot of advantages. One is your ocular surface is intact, you don't have any dry eye. You don't have to invest in equipment. So no expensive equipment, no expensive CMCs.
It's wonderful.
You just have to buy the lens, which the patient pays for. And it is a reversible procedure. You can exchange the lens quite easily. If you're a skilled surgeon, it's quite easy to exchange the lens, remove the lens, deal with most of the issues. The main issue is sizing, but now with newer nomograms coming up, it's much better. It's much better. Of course, I always tell my patients that there's a 2% chance that the size may not be perfect, and we may have to exchange it because we are kind of indirectly measuring the size, and there can be anatomical variations. Not all people are the same. So I give them that, and then they are prepared for it, and I've exchanged lenses. And it's, don't be afraid to exchange a lens.
Yeah.
It's quite easy.
That's true.
If you have a very high vault, a very shallow angle, and you leave it like that, over a period of time it's going to get narrower
Invariably, yeah.
as the lens grows, and you're going to have problems.
Yeah, that's
So
true.
it's, and when you have a very high vault, you would have noticed that the pupil expands. What happens is the ICL or the IPCL is
Holds it.
pressing against the iris, so your pupillary size increases. When your pupillary size increases,
Lot
you
of
have all
side
night
effects,
vision
yeah,
disturbances.
yeah.
So night vision, that's why it's very important to get the right sizing to reduce night vision problems.
Yeah.
If you have a high vault, you have more night vision
Yeah.
problems.
So what is very interesting, yeah.
Suppose you have a patient -8 with 570, 580 cornea. What would you prefer? Smile, femto, LASIK?
Depends upon the age of the patient, depends upon 20, 25, depends upon the topography. No, if the topography is perfectly normal, -7, yeah, you can. See, my limit is up till -8. Anything above 8, yeah, above 8, I prefer an ICL. Below 8, corneal refractive surgery. Yes, because there are a lot of healing changes. The more tissue you remove, okay, the healing changes are more, the epithelial changes are more, then the predictability reduces, the regression also increases, long-term stability is less. With an ICL, you don't have any healing changes, so it's very stable. The long-term stability is very good. PRK for over 8? No, I don't do PRK.
Yeah.
I don't do PRK unless there is a pathology in the basement membrane, if recurrent epithelial erosions, basement membrane dystrophy, that's my indication for PRK.
What is very interesting was, see, whenever we see these irises, is something usually we take back and then we think twice before implanting these
That's
fake.
one of the contraindications.
Yeah.
Don't put in an ICL when there is.
Yeah, but what is interesting is there's this Chinese group who's done a large, this one on unilateral, bilateral eyes, and what is very surprising, almost after they've implanted, almost 50% of the irises actually disappeared post-operative. I think while they're implanting and pushing, and they just
they may have punctured the cyst,
and
but it can recur.
Exactly.
Once
they can always
once it recurs, you can have an angle closure
Angle
in
closure.
that area, local angle closure in that area, and the pupil, once you get a peripheral anterior synicate, the pupil gets distorted, and you can again have it's drawn to one side, and you can have night vision problems.
It's actually can't think of it, but surprisingly they had good results. I don't know how far this one.
But irises
it definitely is.
I would not do
it's a
an
little
ICL in irises.
It's completely. It's true. Okay, thank you.